Welcome,
Hi.
Paul.
Thank you, Dan. It's nice to talk with you.
Likewise. Paul, tell me about your background and how you came to be involved with traumatic brain injury.
Well, I started out working with children with autism and behavior disorders as an undergraduate at UCLA, and I have worked with individuals with disabilities and special needs and behavior disorders ever since. In the late 1980s, I had the opportunity to move from back east to California to work in a brain injury organization, and I have maintained my relationship to organizations and individuals involved with traumatic brain injury since that time.
Paul, what was your training?
Well, I have an undergraduate degree in psychology from UCLA and a master's and a doctorate from the State University of New York at Stony Brook. My license is as a psychologist, but I am also a board certified behavior analyst, which is the primary focus of my professional practice.
Can you explain what a behavioral analyst is?
Well, a behavior analyst is an individual who works with the principles of applied behavior analysis to help people build new skills, to reduce and replace behaviors that are interfering with their ability to be instructed in schools, to maintain themselves on a job. So a behavior analyst is a skill builder.
A skill builder. What types of problems resulting from brain injury would a behavioral analyst address?
Well, among the other consequences of traumatic brain injury, the physical, the sensory, the cognitive, among those deficits, there are often behavioral challenges that individuals face, and they can be things like verbal outbursts or what we call emotional incontinence, breaking into tears or becoming quite angry. It can involve aggression and sometimes property destruction. And those behavioral challenges can limit the kinds of places that people can live after a traumatic brain injury. It can affect their ability to be back in a job or maintain relationships with family and friends. So there can be some significant challenges that are behavioral on top of the other kinds of brain injury effects that people might anticipate.
So these behaviors can really impair the quality of their life.
Well, they can limit dramatically the kinds of activities in which you can engage and whether or not the people that are closest to you are able to care for you. So being aware of why those behaviors emerge and having some methodology for managing those behaviors is, I believe, a critical part of any brain injury rehabilitation program.
Would you please explain how one addresses those behaviors? Let's say there's aggression or some of the other symptoms you mentioned. How would you go about assessing and then intervening?
The first and foremost, it's helpful to educate families and oftentimes the brain injury survivors themselves as to why those behaviors are happening. Understanding why behavior happens is critical to any intervention designed to reduce and replace those behaviors. So a lot of our job is education, helping people understand that if you were an aggressive or an assertive or verbally abusive type of an individual before you were ever injured, that behavior is possibly going to be aggravated and amplified some by your brain injury, because injuries to the brain often limit the brain's ability to filter out things that we generally know we ought not to do.
We're more disinhibited.
We are impulsive and we're disinhibited, but on top of that, we are often disoriented. We're confused with regard to our environment. We don't understand what people are asking us. Our problem-solving skills are limited, so when we get into a bind, we are not easily able to work our way out. And if you are in an environment where you don't understand what people are asking you, and you're not quite sure all the time exactly what the context is because your memory's not so good, it's easy to become frustrated and confused, and that leads to being frightened, and that leads to being sometimes aggressive and verbally abusive. It's also the case that that when the brain is injured, things just come out of our mouths that we wouldn't normally say. And anger and rage in brain injury is very common, but it takes on a very particular kind of a feature. We're used to people who get angry slowly and they stew and they get aggravated and they start to get worse and worse and worse. With brain injury, we tend to have people who just get mad right away at the drop of a hat. And by the time we figure out there's anything going on, they're already calm and don't understand why we're upset. A large part of our job is helping to educate families as to why that behavior might be happening, helping them understand how to not be afraid when the behavior occurs, how to set up environments that are predictable and visually clear to individuals so they know what's expected of them, to reduce verbal input so that we don't overwhelm people with words they don't understand. A lot of that is the educational component of doing good behavior change programming with families.
Mm-hmm. That takes a lot of sophistication and time and effort to try to identify the precipitant of the behavior and then make the plans to intervene in the way you just described. Isn't it easier to just push pills if somebody's out of control?
There's an old saying that if all you have is a hammer, everything looks like a nail. So if you're talking to people primarily who are prescribers, then you're probably going to get a prescriber perspective. But there's nothing wrong with medication as an adjunct to doing good behavior management. In fact, in brain injury, the use of pharmacology along with behavioral intervention is probably critical because there are a lot of barriers in brain injury to doing good behavioral work. Memory is poor, so it's hard to remember what the behavioral rules are. You can understand why you shouldn't engage in behavior, but not remember that from one moment to the next. Impulsivity means that you act very quickly, even though you know you ought not to, and you can tell me that you ought not to. When the situation arises, you're going to do it anyway. Often that means that we need some pharmacological support to help give us sometimes the 5 or 10 seconds that it takes for an individual to say, hey, I think I know a better way, and I'm going to try that way. So I don't see it as an either or. It's very much a collaboration. What I do not like to see is the overuse of medication in the absence of any kind of behavioral attempt to understand why the behavior is occurring.
Agreed. So, Paul, a lot of the effort then goes into educating the caregiver.
Correct. Let me give you an example. I have worked recently with a family who have a young son in his 20s who had a brain injury, a motor vehicle accident. One of the behavioral challenges that he and his family have faced are some very loud but very short verbal outbursts that include some swear words and such, but they're very short and they're very redirectable, but they scare the family. They're frightening. They're unpredictable. They were unpredictable for the family. They were loud and startling. And there was always a sense that something might happen, that there was some other bad thing that was going to follow, compounded by the fact that this is your 20-something baby who is using these words and this tone of voice with you. For this family, a great deal of the intervention has been and continues to be helping them understand that there are actually specific situations in which those outbursts are likely to happen, and helping them understand and therefore predict when they might occur, but also showing them that in this case, doing nothing was the better response, because if you simply took a step back and allowed the individual to vent his frustrations, about 99% of the time, he then calmed down and did exactly what you wanted him to do. So in this case, more of it was helping the family understand that this was something that was unpleasant, but not dangerous, that it was happening for a reason, and that they could survive each of these incidents and not overreact.
So you educated the family that this was an impulsive outburst that wasn't going to escalate and there wasn't going to be destructiveness.
Correct. And in fact, with this young man, because he didn't really remember he ever did this, so he wasn't aware of how upsetting his behavior was, And if you talk to him about whether or not he ought to do this kind of behavior, he absolutely said, no, of course not. I would never do those kinds of things. But he didn't remember that he said that. So we put signs up around his house that said things like, don't scare your mom.
Good. How did that work?
Well, it actually caused him to stop at times and say, I would never scare you. And it was something that he saw every day. And so oftentimes what we have to do, as you know, with individuals with brain injury is we need consistency and predictability and sometimes reminders every single day for people who don't have the memory to build those rules inside their head. So we just accept the fact that part of our role is to be a constant reminder. And fortunately, we live in a world now where technologically we can have those reminders occur with things like phones and computers and other things.
Can you give me some other case examples?
Well, the two general categories that I come across most often, because I tend to work and have worked most of my professional life with the more severe behavior problems. I, for the life of me, don't know how that has transpired, but that's the niche that I have pursued. Sexually inappropriate behaviors are a big issue because they significantly limit access to the community and have legal implications that are significant. So things like touching the wrong people, getting too close to the wrong people, saying things that you think are charming, that are creepy. That's not an uncommon thing with the folks that we work with. They do not intend to be inappropriate. They're not even aware they're being inappropriate, but they are perceived by the people that they engage with as being unusual and intrusive.
I think what you're saying is in many, if not all of these behaviors, these people don't have the control over these impulsive actions. It's not that they mean to harm or provoke or annoy other people.
Well, I think that that is true for the most part with one caveat. And this is where it's helpful to have a behavior analytic kind of approach as part of the team. A lot of behavior is impulsive and disinhibited and not under the control of individuals. But when behaviors occur, they occur in environments that react to them.
Yes.
And those reactions then shape behavior.
Good point. Good point.
We have a gentleman who just loves to pinch the ladies behind and loves to hear them squeal. And so obviously the first line of intervention is teaching people not to be that close to the individual. Mm-hmm. But this is a gentleman who it's no longer impulsive. It's no longer disinhibited. It's very much, I can get away with this, and it's really fun when I can get you to squeal. Mm-hmm. So there are behaviors that are out of the individual's control, but if we react to it in a particular way over time, we can teach individuals that there are great ways to avoid being asked to do things. There are great ways to get attention from people who are not giving you a lot of attention. Mm-hmm. So a lot of the education we're doing with families is about how to make sure you don't make the behavior worse. You may not be able to stop behaviors that are out of the individual's control, but you can certainly work to not make those behaviors worse than they need to be.
Right. Now, I've been told that when a family is advised to make a certain intervention, often the behaviors worsen before they get better. Can you explain that?
Well, we call that in our field an extinction burst. If I'm working with a family that is used to running every time the gentleman in the bedroom screams to say, oh my God, sweetheart, what's wrong with you? Is everything okay? Can I do anything for you? What can I get you? And they may come to me and I might say, you know, there are better and more productive ways for this gentleman to get your attention. And it would even be best if you went into the room before they screamed so that you didn't reinforce screaming. Mm-hmm. Well, the family is maybe delighted with that advice, but the screamer is not so excited. He's not looking forward to having somebody help him stop his screaming. The screaming is working just fine. So when people stop responding to the screaming, he doesn't just say, oh, great, I guess I should just wait for them to come in. He screams louder and he screams longer because he's trying to figure out where the response was that used to come. You see this a lot in toddlers. You know, it's also a very common kid behavior. And so we have to help parents understand, or husbands or wives or caregivers, that when you go about a behavior change intervention, it's not like your client, your customer, the person you're working with, your loved one, is going to be a willing participant right at the beginning.
So your advice is to stay the course.
Is to stay the course, understand why you need to stay the course, and understand that those extinction bursts, when they happen, are generally just days long. They're not weeks and months long.
Can you give me other examples of people you've treated in the home or in a treatment program? What sort of behaviors have you targeted in your treatment, and how you've gone about assessing those behaviors and then suggesting interventions to the parents or the staff?
Most of the work that I've done in brain injury has been in facilities, because that's where I've worked, but that's where most of the more significant behavioral challenges tend to be.
Right. They can't safely reside in the community.
If the behavior challenges are significant enough, the community has a very limited tolerance for challenging behaviors. And more than that, the families have very limited tolerances. It's important that I continue to remind myself that the 5 seconds before a brain injury, that person was me or any other family member of mine. And in those 5 seconds, not only does the brain injury occur, but everything about that family changes, everything. And so it may be easy for an outsider to think that a family ought to just buck up and take care of their loved one, but the challenges for caregiving for an individual with a brain injury are significant, and they're only compounded 10 times if that individual is angry, is violent, tends to run out of the house, steal your car and try to drive away. And so often those individuals have to then live in another environment.
So it's their own safety, the public safety, and to try to lighten some of the caregiving load of the family.
Sometimes the most fulfilling part of the work that I know I've done with my colleagues in the facilities we've worked in is to offer, for the first time for some families in many years, the relief, the comfort of knowing that their family member is safe, their family member has a quality of life, but that the family themselves can sleep at night, can take care of each other, focus on the nurturing and support of the remaining family members. Sometimes it's the difference between being able to stay on a job or not stay on a job. The fact that they know that their loved one is with someone, with people who can safely take care of them, manage those behaviors, and give them a dignified and respectful quality of life. That's even more important when the individual is significantly behaviorally impaired, because there are a limited number of people in the world that know how to and want to work with individuals who are dangerous and unpleasant and defiant. And those are the kinds of behaviors that we sometimes see. Now, there are very mild versions of all of these things. It doesn't mean that all behavioral challenges after brain injury are major.
True.
The principles underlying how you work with them remain the same, whether the behaviors are mild or very severe.
Mm-hmm. Can you say a little more about the specifics of collecting data and then formulating an intervention?
The first thing that any behavioral intervention requires is an assessment. And generally what we're looking at is something that is called a functional assessment of behavior, which is to look for the relationship between the behaviors that are occurring and the environments in which they're occurring. Why are the behaviors occurring? Where are they occurring? With whom are they occurring? We're looking for patterns of occurrence that tell us something about what environmental events may trigger or set the occasion for the individual to say, this is a pretty good time to use my bad behavior. For example, I'm in a situation I don't like. You're asking me to do things I don't want to do. I'm going to find a way to let you know to leave me alone. Well, I may ask you to leave me alone and you may not. And I may say very firmly, please leave me alone, I told you, and you may not leave me alone. And then I may scream at you very loudly with threats and curse words, and you may say, well, if you're going to scream at me, I'm not going to work with you. So that's one of the reasons why people engage in behavior, is to make you go away. Part of the assessment is to define the behaviors we're looking for, talk to the people who work with those individuals with those behaviors, observe the behaviors directly for long periods of time, collect data to look for patterns of when the behaviors are occurring, so that we can answer questions like, the behavior tends to always occur when I ask you to do something. The behavior always occurs when I've left you alone in your room for too long and I haven't spent time talking to you. Maybe those behaviors are designed to make sure that you pay attention to me. So we do an assessment designed to look at not only the behavior, but where and how in the environment is behavior occurring, so that we can look for patterns that we can then educate people about. Then our job is to build interventions that teach people how to make sure that the environments are not overly demanding or demanding in ways that are confusing and aversive. We make sure that attention is readily available to people so they don't have to act inappropriately to get it. We teach people other ways to let us know what they need. And a lot of the time we teach parents, caregivers, program staff, how to prevent behavior from happening by watching for the signs that things are going wrong before they go wrong, and intervening quickly rather than waiting for things to deteriorate.
It seems like a very effective way to intervene, but it requires time and effort to collect the data and then to teach and reinforce the behavior of the caregiver.
Yes, to do it consistently with very significant behaviors, it requires an environment which is prepared to do the day-to-day work, data collection and observation and consistent intervention. If you're in the homes and you're really just working with less severe behaviors, there are ways to do this where there are shortcuts. There are more simplified strategies that you can teach families that are eminently doable. The complications arise when the behaviors, as a result of the severity of the injury, are much, much more severe and potentially dangerous.
What do you see as the biggest challenges in your work and the biggest satisfactions?
Well, the thing that has kept me almost 50 years in this field as a behavior analyst, when behavior analytic interventions work, you're essentially changing people's lives. And there is no job in the world that gives you satisfaction as much as being able to actually see that something you have done changes the quality of somebody's life. To allow an individual to remain in their home rather than having to go live in another facility. To allow an individual who could not go out in the community to be safe out in the community, to do a job. Those are all things that are extremely rewarding to me. The biggest challenges in the entire field of brain injury are, number one, public education. It's not a glitzy field. It's not particularly well known to people unless they've been affected very directly by it. Not a lot of telethons and fundraisers. We have to constantly be reminding people the impact of even minor brain injuries on quality of life. And related to that is simply funding. For every individual that comes to an organization that I might be involved with, there are probably 100 who need to come for services for whom there is no funding. That to me it's a tragedy. And it's an ongoing process to make sure that families who are in need of services get the services that they need.
So what advice do you have for families, and what advice do you have for healthcare providers in dealing with these behaviors?
The best advice I would give to families is seek support. Don't do this alone. Here in San Diego, where I am, we have an organization called the Southern Caregivers Resource Center. They are a great resource for people who are finding themselves suddenly in a caregiver role. The San Diego Brain Injury Foundation. There are brain injury courses at local community colleges. Don't try to do this alone. Join a community of people who have already gone through this and can help walk with you through the process. Learn about brain injury. The more you understand why the individuals around you are acting the way they are, the less scary it is. So educate yourself through podcasts like this and through lots of online resources. I think that doing that really does help keep families from becoming isolated and despairing over their circumstances.
Good advice, Paul. How about for healthcare providers?
Patients, again, be aware and be educated. Oftentimes, when our folks have to go into the hospital system because they're sick, they're ill, it is easy for people in healthcare to look at our folks, our brain injured folks, and just be simply at sea. They just don't know. They are completely befuddled with regard to what to do with individuals with brain injury. So I think anything that has to do with more education for healthcare providers with regard to what brain injury looks like, what some of the consequences of brain injury are, and understanding that you can, even within healthcare settings, create environments that can support people with brain injuries and reduce the frustrations and challenges that lead to behavior problems.
Good advice again. Paul, what else would you like to add?
I am very happy that in the last several years, my field, which is behavior analysis, which has largely been focused on areas like autism, has found its way into traumatic brain injury. More individuals with behavior analytic backgrounds are now becoming interested in working in the brain injury field. I think that's a great trend. I think that the combination of behavior analytic clinicians with rehabilitation clinicians and families is a tremendous benefit to the whole rehabilitation process, and I'm excited to see that trend.
A behavioral analyst would be a very valuable addition to a treatment team.
Yes, I believe so. Selfishly, yes, I believe so. The right behavior analyst who is willing to learn and to apply their behavior analytic skills to a population that is going to make them work harder at what they do. But I think the benefits for all parties in that case are tremendous.
So, Paul, I appreciate your taking the time and effort, and I thank you very much.
It's been my pleasure.
I hope you liked this video, and please let me know in the comments what questions you have and what other topics you'd like me to discuss.